Thanks, Heather. Kia ora tātou, and thanks, Sunita, for helpfully explaining the NZ PrEP study, which I guess because it's an early access scheme, is also a study of early adopters of PrEP in New Zealand. And that's what I'll be talking about today. So this is the behavioural arm of the NZ PrEP study. And just off the bat, I wanted to re-emphasise that this is a real collaborative effort, so it wouldn't be possible without the dedication and generosity of a number of organisations, and particularly the funders, and I want to include ADHB in that as well. So of all the previous speakers have mentioned, PrEP's here, whether the New Zealand health system is ready for it or not, and that raises some really important questions about, or community and public health questions around issues like acceptability, feasibility and implementation. So the aims of our study were to describe the baseline characteristics of early PrEP adopters accessing funded PrEP, so fully funded PrEP, in the context of a sexual health clinic, and that's what we'll be talking about today. And then at a later date and pending funding, we want to follow respondents over time and identify factors associated with suboptimal retention and adherence, and also factors associated with sexual behaviour change. So that's what the overall goal of the study is. As Sunita mentioned, we're funded for 150 participants. Again, to emphasise, this is a demonstration project. It's not an access scheme or implementation scheme. So we're interested in questions about acceptability, feasibility, and implementation, and optimising those targets. So consequently, equity is a really important principle for us. And so we want to make sure that we've got sufficient study power to investigate the experiences, particularly of ethnic minorities. So we proposed 2 recruitment quotas. The first one being that we wanted half our sample to be non-European, and also that we wanted 20% of our sample to be Māori. So we can investigate the experiences of those 2 groups within our study over time. How it works is that after each clinic appointment, respondents are emailed a link to the questionnaire, which is online. They can self-complete it online themselves. And we're able to check that they've done that because of a unique study ID that's embedded into the email that's sent to them. We have learnt from the Australian experience, and their early demonstration projects were very large. We've reduced that substantially, but it still is 70 items long. It really is an opportunity to learn a lot about this first wave of a new technology. And they cover the typical domains you'd expect, so sexual history, testing history, and attitudes to a wide range of issues. The data are held and analysed separately at the University of Auckland, so they're not linked to the patient records. In fact, I'm the only person who sees the individual sponsors, and I don't know who they are. So 6 months in, we've got 114 completions, which is about 3/4 of our target sample of 150, majority recruited from Green Lane Clinic, and that's about 15 to 20 enrolments a month over the first 6 months with a busier August. As Sunita explained, we're already at about 45% of our sample being non-European, so that's really encouraging, and we'll probably stop recruiting Europeans to get that up to 50%. Just under half the sample are younger gay and bisexual men, and majority identify as gay, which again I think is what you've seen in the Australian experience. So over 98% of our respondents prior to their clinic visit were aware of PrEP, and I think that says a lot. And the most common sources cited as sources of information about PrEP were generally gay community sources, so friends, social media, online dating, as others have pointed out. And that stands in contrast to a much lower recollection of information from GPs and from marketing or other information ads. So I think that tells an interesting story. Not unexpectedly, the majority of our participants raised the possibility of joining the PrEP study themselves, whereas about 30% were recommended to do so from their nurse or doctor. And the main reasons people cited as agreeing to PrEP were things like, I want to do everything possible to avoid HIV, I'm at risk of getting HIV, I needed more prevention options. But also just over half cited that it being fully funded was also a really important consideration of them joining our particular fully funded PrEP study. So I think taking all that in, it paints a picture of a population that's highly engaged, highly motivated, it senses itself as being at risk of HIV, and it wants to do something about that proactively. It's a highly clinically engaged sample already, so over 90% have had an STI and an HIV test in the prior 6 months. All, of course, of our sample on enrolment are HIV negative, but it has a high STI profile. So around 70% of our respondents had an STI diagnosed in the previous 12 months, and 43% of that were rectal STI. So that's consistent with their own idea of themselves of being at high risk of HIV. The most common STIs were chlamydia and gonorrhea, and about 10% reported syphilis. That profile makes a lot more sense when we look at their sexual behaviour in the last 3 months. So this tells us the median number of male sexual partners with a 95% confidence interval and range for 4 different categories. From the left to the right, all men, anal intercourse partners, condomless anal intercourse partners, and receptive condomless anal intercourse partners. So taking the right-hand one here, about half the sample reported under 4 receptive condomless anal intercourse partners in the last 3 months. About half the sample reported more than 4, and the maximum was about 50. So it's a very busy, active, passive sample of gay men. This is the same data, but displayed a different way. This is looking at, with those 4 categories, the proportion of our respondents reporting more than 10 of these partners. So looking at the right-hand side, about 12%, or 1 in 8 of our respondents reported more than 10 receptive condomless anal intercourse partners in the last 3 months. And if that seems implausible, rather nicely, that's almost exactly the proportion that was found at baseline in the UK PROUD study when we combined the immediate and the deferred treatment arm. So it tells us that we're seeing the same sorts of clinic populations as they did in the UK, which is really nice. And I guess to push the point home that this is although it's a sample without HIV, is at high risk of acquiring HIV, either because of their own behaviours or their sexual network placement. Around a half reported group sex in the last 3 months, half reported using drugs before sex in the last 3 months, 8% meth use before sex, 6% injecting in the last 12 months, and 23% reported a post-exposure prophylaxis prescription at least once in their life, which is really high for New Zealand given that it's not widely promoted. We have a large battery of attitude items, a large battery. This is just some examples to give you a flavour of the sorts of issues that our respondents are grappling with. So around a quarter think it's quite likely that they would become HIV positive in the next few months. About 90% believe that the PrEP pills will keep them HIV negative. About 37% reported that they thought that missing a pill for a day wouldn't matter in the long run, which is, I guess, technically correct. And around 25% said that they worry about becoming too dependent on the pill. So quite a number of issues that are already occupying our respondents' thoughts. And then we asked for some free-form write-in responses at the end. This is really interesting because I've just highlighted one theme here, which is it emerges quite independently, which is around the respondent's sense of responsibility. And I think it's really important. This is unprompted. So respondents, of course, talk about PrEP being something that protects themselves, but they also talk about it as a way of protecting their partners and as a way of protecting the community. And they also talk about the importance of an expert and non-judgmental and skilled clinical workforce in terms of providing a welcoming environment and a service that they feel really comfortable accessing. So in summary, I think we've demonstrated that gay men can be engaged about PrEP and enrolled in the setting of a sexual health clinic. Early PrEP adopters are a very high-risk subset, and I think that's consistent with what we understand what will happen at the breaking wave of a new technology, which will be the men who are most at risk and who would benefit the most from the technology, who have the highest interest. So that satisfies the study aims. We need to follow up the sample over time, identify changes in behaviour, suboptimal outcomes and the factors related to that, and we're still seeking funding for that. So if there are any funders in the audience, we're really keen to talk to you afterwards. I just want to acknowledge again all the supporters, the study team, and in particular our participants. Thanks.